Hi, my name is Clinical Class and you're watching the video Third Cranial Nerve Palsy, Clinical Characteristics. In this video we'll be discussing what we expect of a motility exam of a patient who has been diagnosed with a third nerve palsy. As you're aware, the third cranial nerve supplies a number of extraocular muscles. Indeed, it supplies all extraocular muscles apart from the lateral rectus and the superior oblique, which are supplied by the sixth and fourth. It also supplies the levator, the pupil and the ciliary muscle. However, with a neurogenic palsy of the third nerve, it may not necessarily affect all muscles. It may affect some muscles and not others, and in some instances it may spare, for instance, the pupil and the ciliary muscle. Let's have a look at how we divide the types of third nerve palsies we can have. Okay, so we can have a complete third nerve palsy, and this means that all the extraocular muscles have been affected. However, in some instances, the pupil may be involved or it could be spared, and we'll talk about this in a moment. It could be incomplete. Incomplete refers to where we have a third nerve palsy that's only actually affected one of the divisions. Recall there is a superior division which supplies the superior rectus and the levator, and then we have the inferior division which affects all other muscles supplied by the third. We could also have an isolated muscle palsy, and what I'm referring to there is you could affect just one extraocular muscle of the third nerve. So for instance, the superior rectus alone or the inferior rectus alone. Okay, and as usual, we can have total or partial paresis, so we can have a total paralysis of the eye, or we could have a paresis where there is some function of the extraocular muscles. And dependent on whether we have a complete or incomplete, a total and partial, you will see different characteristics or differences between each of these third nerve palsies. Okay, so here's a flowchart of what we've just discussed, where we have the third nerve palsy. It could either be complete or incomplete. With your complete, it could be total or partial, and here we could either have pupil sparing or not, depending on the situation. In terms of incomplete, this can also be total or partial, but also we could have a division of the third nerve affected, so either the superior or the inferior, or we could have an isolated palsy where one of the extraocular muscles that is supplied by the third nerve is affected. But even though you can't see it on the flow chart, please be mindful that a complete can be total or partial as well, in terms of the extraocular muscles affected could be paralysed or could have some partial function. Let's start off with the complete third nerve palsy. What do we expect of this patient in terms of their deviation in primary position? And this is what we refer to as the ocular posture. Now, if you think about it, in a third nerve palsy, you've affected all extraocular muscles, if you have a complete third, other than the lateral rectus and the superior oblique. So these two muscles remain unopposed, and therefore the lateral rectus will take the eye out and the superior oblique will take the eye down. So the hallmark deviation of a complete third nerve palsy is an eye that's down and out. And here we see a patient with a left third nerve palsy, and we can see it's out and it's down. She also has a ptosis, which we see in the second image here. We'll come back to this in a moment. Having a look at the Hess chart, we can see this ocular posture here as well. So here we have a left complete third nerve palsy, and what we see is the eye is out and down. We also see the underaction of a number of extraocular muscles, the superior rectus here, the inferior oblique here, the inferior rectus here, and the medial rectus here. So here we have a complete third. Let's have a look at a patient in 9 positions of gaze. In this instance, we have a right third nerve palsy, and we can see in primary position we have a right ptosis, and the eye appears to be out and down, although it would be easier if we had that lid lifted there. Okay, the patient looks over into this position of gaze. We can see the lateral rectus function seems to be okay, as well as the medial rectus function of the left eye. Patient comes up and we see a limitation of this right eye in elevation. Patient comes down and there's a limitation of depression in this position. So we have an underaction of the inferior rectus here and an underaction of the superior rectus here. Moving on to left gaze, we now see that the patient is able to abduct with the left eye, but has limited adduction here. So we have a medial rectus underaction. And the patient is trying to elevate here. It's difficult for us to take a look at the inferior oblique here because we have limited adduction, but there seems to be a limitation in elevation, or the eye is struggling to elevate in this particular position. As we take the patient down, we can see that the eye does appear to be going down, but again, because we have limited adduction, it's very difficult to have a look at the superior oblique in this particular instance. I'll talk to you a little bit more about how to look at the superior oblique in a moment, where you have a third nerve palsy. Okay, so given the extraocular movements that you've just seen on the Hess chart and in 9 positions of gaze, you're expecting that this patient is going to have significant diplopia. It's generally horizontal and vertical, and they generally do not complain of torsion. Now, where a patient has a ptosis, they will not complain of diplopia, as the ptosis will give them single vision or monocular single vision. The other possibility is that where a patient has a large deviation, the second image is rather remote, so the separation between the images is very large, and this creates the opportunity for the patient to be able to ignore the second image, and they may not complain of diplopia even if present. It might not be bothersome for them. If the patient is able to ignore the second image because it's far away, or if a patient has a ptosis, clearly there's going to be no abnormal head posture in this particular instance. Where a patient doesn't have a ptosis and they do or are bothered by the diplopia, they can sometimes find an area of BSV, and this will usually be to the unaffected side. So if we have a right third nerve palsy, we will move our head to the left to get that eye, the right eye, into abduction, where the lateral rectus is functioning and the medial rectus of the other eye, of the left eye in this instance, is functioning. There may be some BSV in that position. Okay, we've mentioned so far the ptosis that a patient may have, and we can see here the patient to the right is having their right lid elevated. We can see the down and out eye, but now we also see there's pupil dilation here. So because the third nerve is supplying not only the extraocular muscles in the levator, but also the sphincter pupillae and the ciliary muscle, we will have issues with pupil. With the pupil, you'll have a dilated pupil, and we can have an accommodation palsy in these patients. So patients may complain of uncomfortable vision as they have an issue with one of the eyes accommodating. Now, you would have noticed earlier I mentioned pupil sparing, that in cases where you have a complete third nerve palsy, where all the extraocular muscles are affected, we may have the pupil affected or not affected. The reason this is the case is because the parasympathetic fibres for the sphincter pupillae actually run superficially along the nerve. So we can see here they run superficially along here. So where we have a space-occupying lesion, for instance, that's actually compressing on the nerve, the sphincter pupillae or the parasympathetic fibres will be affected and will have pupil dilation. However, where we have a microvascular lesion, such as we see in diabetic patients, this actually happens more deeper within the third nerve, or more deeper within the nerve. In this instance, the parasympathetic fibres that are running superficially along the third nerve are spared. So where you have pupil involvement, you need to consider the possibility that there's something compressing on the nerve. And this is one of the signs of a patient needing to be scanned or having an MRI, CT scan, depending on what's appropriate. Now, earlier I mentioned that it can be difficult to look at the function of the fourth nerve in patients with a complete third. You have to consider the possibility that the patient actually has multiple cranial nerve palsies. They could have a third and a fourth. So you need to establish that the fourth is functioning. So if we have a look back at the patient we were looking at earlier, this is where we were trying to assess the superior oblique. So the patient is trying to adduct the right eye that's affected and come down so that we can look at the superior oblique. But the patient is struggling to adduct, which gives us that limited view of the superior oblique. What you want to look for in this instance is, as your patient is attempting to look into lavodepression, you want to pay attention to this eye. You want to have a look, say for instance, at a blood vessel here, And what you want to do is concentrate on that blood vessel as the patient attempts to look into lavodepression. And what you want to look for is see if you can see intorsion of the eye or encycloadduction of the eye as the patient is trying or attempting to move into lavodepression. If you can see intorsion of the eye, you can conclude that the fourth nerve is likely to be unaffected. You can also use an iris landmark. Say the patient has a landmark that you can look at on the iris. You can look at that and try and see if there's intorsion of the eye as it depresses in adduction. Okay, you may also have issues assessing the sixth nerve or the lateral rectus where you have a patient with a very large exotropia. So in this instance, if in doubt whether the lateral rectus is functioning and whether abduction is full versus the eye is already almost completely abducted because of the exotropia, then have a look at saccades or have a look at force generation tests to determine whether that lateral rectus is functioning okay. If you indeed have both a third and a sixth nerve palsy, then generally the sixth nerve palsy, which causes an esotropia, and the third nerve palsy, which causes an exotropia, will counterbalance each other. And so what you'll have in prior position is often a small exotropia, or possibly even an ESO, but generally it'll be a small exotropia. Now this should be an indicator that likely you have a lateral rectus affected as well as a third nerve. So that's another feature you can look at in assessing a patient with a third nerve palsy and trying to determine if the lateral rectus is unaffected. Okay, let's move on to incomplete third. So now we're going to be looking at the superior division being affected versus the inferior division. Let's commence with the superior division. Now remember, the superior division supplies the superior rectus and the levator. So what we will see is a palsy that's consistent with the superior rectus palsy, and we will have a ptosis. If we have a look at the patient here, we have a left superior division third nerve palsy. We have a ptosis that we can see in prime position, and we have a hypo deviation. And this is because indeed we have a superior rectus palsy, which means that one of our elevators is affected, in which case we'll see a hypo deviation. And as we take the patient into left gaze, we can see that this hypo deviation persists, and as we take the patient up here, we can see the superior rectus is not elevating, and when we take the patient down here, we can see the inferior rectus is overacting. At this point, I want to bring your attention to the condition called a pseudo-ptosis. What is a pseudo-ptosis? A pseudo-ptosis is where there appears to be a ptosis due to the hypodeviation. Now, have a think about when you are assessing a patient and you have them in prime position and you move them down into down gaze, the lids come down with the eyes, and this is why we often lift the eyelids in down gaze so we can get a better look at the eyes. Well, if your eye is down, the lid will come down with it. So if we have a look here at the patient to the right, this patient is fixing with their left eye and has a right hypotropia, and we can see a ptosis in this particular instance. When the patient is asked to fix with this hypertropic eye, here we go, the patient is now fixing with the hypotropic eye, and the patient now has a left hyper. And as the patient fixes with this eye, you can see the lid has now lifted. This is a pseudotosis. The patient has a ptosis, or what appears to be a ptosis, simply because we have a hypotropic eye, and when the eye is down, the lids come down as well. And so one of the distinguishing features is that if you ask the patient to fix with the paretic eye, as has the patient done in this particular image, what will happen is the eye will come up and so will the lid. So this is a pseudotosis. A ptosis patient, if they were fixing with a paretic eye, the lid would not come up. It should just stay down because the levator is affected. Moving on now to an incomplete third, that's affected the inferior division. So with the inferior division, we actually have all extraocular muscles that are supplied by the third nerve except for the superior rectus. So in this instance, we usually see a hyper deviation in prime position. And here we have a patient with a inferior division third nerve palsy, and we can see she's got a hyperdeviation here. And when we take her across into left gaze, we still have a left on right here, and when we take the patient here, the superior rectus looks as though it could be okay. A cover test would be required. But when we take the patient down here, we can certainly see the inferior rectus is not depressing the eye. Okay, moving on to right gaze, we can now see that this eye will not adduct. As we take the patient up, we're not getting a good look at the inferior oblique here. And as we take the patient into down gaze, we can clearly see this eye is just not getting down. So here we now have the dilemma of whether the superior oblique has also been affected with the third nerve palsy. We can also see in this particular instance that the pupil is relatively dilated. And finally, as I mentioned earlier, we can have isolated muscle palsies where one of the extraocular muscles that are supplied by the third nerve are affected singularly. We'll come back to this in another video. Before we conclude this video, I just want to bring your attention to a condition that could be misdiagnosed as being a third nerve palsy. This is the double elevator palsy. The double elevator palsy is a condition where there's limitation of elevation in both AB duction and AD duction. Have a look at the patient to the right here. This is them in primary, down gaze and up gaze, and this is dextro elevation and lateral elevation. And we can see in dextro elevation that the superior rectus is limited, and the superior rectus is supplied by the third nerve. When we come over to lateral elevation, the inferior oblique is limited, and this is also supplied by the third nerve. And in direct elevation, we obviously will have limited elevation as both the superior rectus and the inferior oblique are affected. Now, this is not a third nerve palsy. It's considered to be perhaps a tight inferior rectus in most instances, and it could even be of supranuclear origin. So bear this in mind, and it's important to distinguish a third nerve palsy from a double elevator palsy. And a double elevator palsy will not have the other signs of a third nerve palsy, such as the medial rectus underaction, and we can even see here, even though we don't have the patient in adduction, we can see that the right eye is making it across, it's just not elevating in this particular instance. In summary, a third nerve palsy can be total or partial, so it can be, we can have total paralysis or a paresis where there is function of the extraocular muscles. We can have a complete third where all the extraocular muscles have been affected by the palsy, but in this context we can also have pupil sparing, or we could have pupil involvement. So always look at your pupils and ensure that you identify whether the pupil has been involved or not. Again, if the pupil has been involved, then we need to consider space-occupying lesions and consider patients being scanned. We can also have incomplete third nerve palsies where either the superior division or the inferior division is affected, or where a single isolated muscle palsy can occur. Okay, to the right we have a table here from Ansons and Davis, which includes some of the hallmark features of a third nerve palsy where you have either all the muscles affected, the superior division or the inferior division affected. Okay, that brings us to the conclusion of this video. Thank you for watching.